Thank you, Magda, and congratulations to you and IMI for organizing this impact series. And fantastic that diabetes as a disease was at the forefront. And yeah, this is very important to us. Next slide, please. I am a clinician, and I do advise most companies who make tools and agents to help us treat people with diabetes. And if it can be of any consolation to Ken, when it comes to therapeutics, we have seen an explosion of therapeutic agents and tools allowing us to really affect outcomes in people living with type 2 diabetes. Even more so, I can tell you, than in people with type 1 diabetes. So it's not really a competition, but I do acknowledge what both people living with diabetes have said. It is a very special beast that is not comparable to any other disease, whether it's type 1 or type 2. And next slide will show you the picture of 2021. It's not a COVID molecule, but it is, to me, this picture of a mother with a dying child 100 years ago, because that was what type 1 diabetes was, namely a mortal disease. And it was thanks to the work of 4 men in Canada, in Toronto, that we have now insulin as a treatment in our hands. And in January 1922, they administered it for the first time to a child dying of type 1 diabetes, turning it into a chronic disease. Because, next slide, we know, and Veerle and Ken said it, that indeed we have turned type 1 diabetes into a chronic disease. And it became clear in the 40s and 50s that that's not the end of the story, because diabetes affects many organs and leads to life years lost. If you are diagnosed as a little girl before the age of 10 with type 1 diabetes, you lose more than 15 years of your life in 2021. So it remains, pardon my English, a shitty disease, and we need to do something about this. We know in type 1 and type 2 that we have now tools like insulin, but also other tools where we can affect glucose control, where we can affect outcomes. But it's, you know, the big question is, can you make it go away? Next slide. And so this is a slide that was given to me by one of my patients living with type 1 diabetes, who says, Dr. Mathieu, this is how I feel. Walking a tightrope every day with my insulin doses needing adaptation depending on what I eat, what I do. And underneath me are the crocodiles of hypoglycemia acutely and hyperglycemia with chronic complications in the long term. And that brings a lot of stress. And indeed, severe hypoglycemia is an issue. And it is an issue that Veerle said it so fantastically, you know, waking up in the night, needing to help yourself. But let's not forget, severe hypoglycemia has dramatic implications and also mortality acutely. But also chronically, we know that severe hypoglycemia leads to fear of hypo, reduced quality of life. And therefore, next slide, I was very happy to see that IMI had this project, Hypo Resolve, where Ken is in the patient advisory committee, really focusing on how to address hypoglycemia as a problem, not only in type 1, but also in people living with type 2 diabetes. And Ken, let's not forget all these people with other forms of diabetes because of, you know, their pancreas being taken away or needing steroids in their treatment, etc. So diabetes is a monster with many, many, many faces. But hypo is one of the issues many people are faced with as having diabetes. Next slide. So I want to go on talking about really the question of this little girl. Can you make it go away? Can you prevent or cure type 1 diabetes? And next slide. This is really what we tried to do in these 2 projects, Inodia and Inodia Harvest. And again, our strict timekeeper, Ms. Gunn, told me to be very, very brief, focus on on the achievements. So I invite you to go to our website, inodia.eu, to see what we're doing, but I'll just pick some highlights. Next slide. So the first thing we did with Inodia and Inodia Harvest is really realize for this very specific disease, and I know IMI doesn't like disease focused and organ specific, etc., but you can do generic things, but for specific diseases, you need to go in depth. And so here we were very fortunate to have this public-private partnership, not only between industry and academic centers ranging from basic to clinical, but also we have JDRF in our midst. We have the Helmsley Trust in our midst. So having foundations in the middle of this whole research environment is of crucial importance. Next slide. So again, these were the objectives. And the first thing we wanted to do was to create an EU infrastructure and network where we have all kinds of researchers going from basic to applied, clinical, industry and academic working together, having a collaboration to really discover new biomarkers in type 1 diabetes, because that's still an issue. We only get to the diagnosis of type 1 when hyperglycemia is there, when high blood sugars are there. And we know that years before that, the disease is already ongoing. And so understanding better and being able to predict better who will get the disease is one of the big objectives of Inodia. But so we put a lot of effort in making this big network, logistical network, making all these centers collaborate, from Poland to Belgium, from France to Finland, everybody working together in a very standardized way. And also bringing together all the data into one unique integrated database, allowing deep dive, allowing systems biology analysis of all the data, the omics analysis, a gazillion of data, bringing the problem of type 1 diabetes together. Also bringing all the samples together. And then finally, we also wanted to come to innovative clinical trial designs, because type 1 diabetes is a very special animal. I do a lot of clinical research in type 2 diabetes, but type 1 demands very specific approaches. It's studies in young people, in children, it's pediatrician, adults, adult endocrinologists, it's immunologists. It's really a whole mixture of people who need to work together. Next slide. And so Magda, when you ask me what we have realized, we have indeed developed now this big EU infrastructure with more than 40 partners, with many clinical satellites also working together, and we have generated an unrivaled bioresource in type 1 diabetes and discovery science. Also, the fact that we brought together basic researchers, clinical researchers, industry, academia, and at the center, the people living with the disease and the families living with the disease, that was very important. And so we are now also running our first clinical trials, which is also of great importance. Next slide. So the organization, very briefly, I will not go into that. It is quite standard for European projects, but just to bring together in this first work package, this whole clinical EU consortium of people participating into this, donating their blood, donating urine, donating stool, it's not a given. And again, our patient advisory committee was central in motivating people to participate in this effort. Next slide. But then having very standardized ways, very standardized laboratories, doing basic research, bringing novel biomarkers into these clinical samples was very important. And then next slide, having the possibility of a central clinical research file, the ECRF central, but also this possibility of overarching systems biology analysis of all of the data is crucial and central to Inodia. And finally, as said, the clinical trials. And at the center, next slide, is really this patient advisory committee. Next slide. This is one of my pet slides, and you can go on because it's animated. You know, it's of the people, by the people, for the people living with type 1, because that's everything. And they keep us on our toes. When scientists present data at the annual meeting, the patient advisory committee gives out a prize for the best communication, and they stimulate the young researchers to talk their language. Not that what does it mean, not just translating, but what does it mean to me as a patient. So next slide. Just some overview. Yeah, here you can see the people, and again, we have people flowing in, flowing out. Next slide. Some data, Magda, what have we done? Well, we have, in the meantime, we said we would recruit 5,000 people. We are at 5.5 years. We are at 4,900 with many newly diagnosed. And you see the little blip of COVID, but we survived. And I mean, our clinical teams and our patients and family members are so motivated. It's a humbling experience coordinating this network. Next slide. Yeah, so again, just a glimpse of all the omics. It's millions of data points, Magda, coming together in one big database. And now it's really machine learning doing everything, and you'll be seeing big things coming out in the next months and years. Next slide. Also, just the logistics, and this is not high science. And again, people at IMI and the reviewers, they may say, oh, Dr. Mathieu, is that what you are presenting? Yes, this is what we are presenting. But this is what is needed to do research in Europe. We're not the United States of Europe. We are a conglomerate of countries with different legal requirements, with different ethical requirements, and shipping samples, I can tell you, from one country to the other to another is not easy. And Brexit didn't make things easier. But anyway, we're still doing it, and doing it with pleasure. Next slide, please. What we also absolutely wanted is indeed this central database. Next slide. And what is important, it's not only to have the data present, but to have the quality control. And so real time, we follow samples from the arm of the patient to the database, through the laboratory. And again, boring stuff, but essential stuff. Because if you want high quality data, you need high quality samples. Next slide. And then another thing I want to accentuate is we also wanted the basic researchers there. Next slide. And how can you measure basic research? That is by publications, of course. And here you can see the evolution of the publications and the joint publications that we have in Inodia. And it is really amazing to see how this is also growing. Next slide. And then finally, the clinical trials. Magda, I promised to offer you just a glimpse. It is 2 projects. It is Inodia with 1 clinical trial, and it is Inodia Harvest, because we were so successful, with 3 clinical trials. Next slide. And again, it's not easy to organize this in Europe. And so again, a lot of logistics with the clinical coordination center on top, with an Inodia clinical trial prioritization committee, because we're getting more trials offered than what we can run. So we need to prioritize in a democratic way. We have day-to-day clinical trial running. It is an amazing machinery. And I can tell you, we will make sure that this is sustained after the projects end. We want to make this into a professional trial network running in Europe. Next slide. And so just a glimpse to end of the trials that are running. We have 2 academia-sponsored clinical trials, MELD ATG, which is a trial running in young adults and children down to the age of 6 years, down to the age of 5 years, I make a mistake. And it is testing in an adaptive trial design, so very complex trial design based on our IMI approved master protocol, whether we can go to very, very low doses of an agent, anti-thymocyte globulin, administered 2 days at the time of diagnosis, and you can see the countries that are open and the countries that are soon to be opened. Also, the Vera-T1D trial, a verapamil trial with an old drug, repositioning it in type 1 diabetes in adults this time, sponsored, the first one is sponsored by my university clinical center, and the Vera-T1D study is sponsored by the University of Graz in Austria. And then 2 industry trials running on top of Inodia, one by IMSIs, studying emotopes, again in young adults, and one study by Novartis called the Iscalimab trial, which is a study running partly in Inodia, partly outside, running again in newly diagnosed people, in young adults, but also going down to younger ages. And then next slide, I want to end by thanking you for your attention. Do go to our website, inodia.eu. Do follow us on Twitter and LinkedIn, and yeah, join us.